very delighted to be selected by the organizers for me to present bloodless myomectomy. It's a delight because this is the area that I'm very much interested and part of my area of interest, the oncology unit. By the time we finish this particular session, I expect that most of the participants will be able to appreciate particularly some of the clinical and pathological factors that relate to increased blood loss during myomectomy. This is important because it will help you in the selection of patients that you'll be able to prevent excessive loss. We'll also be able to appreciate some of the interventions that will help to reduce blood loss during myomectomy, and also postoperative management of some of these patients, which is very, very important, because when you have finished your meticulous surgery, postoperative intervention that is defective may likely lead you into not achieving the set goals. In the course of the discussion, we are going to present our own experiences in University of Calabar Teaching Hospital. So, by way of introduction also, let me say that the theme of this conference is quite apt. The fact that we are to bridge the gap between knowledge and practice. This had been my area of concern, because particularly in this area, you have a lot of knowledge, but practice is lacking. And if we can, in this session, try to bridge the knowledge that we have and practice, it will go a long way to saving the patient and the society at large. I was tempted to modify the topic of this presentation, because there's nothing much I will say that many people do not know, to the fact that we are practicing in low resource setting, that my presentation will essentially amplify what we do in our setting here because of constraint of facilities, constraint of material, constraint of economy, constraint of even the profile of the patient that we have. Because some of our patients are poor, ignorant, religious fanaticism, and all that. So if in my presentation, I will try to amplify this for us to know that the practice in the low resource setting is a little different from what we have in other advanced settings. It is a multidisciplinary approach that we are going to use in managing cases of bloodless myomectomy, which means it cut across almost all disciplines, putting head together to achieve the result. I had mentioned the profile of our patient, which is very important, and most of the resilience of the practitioner. Because I know when this bloodless medicine stuff was introduced into our society, the resistance by the general public, and in particular our colleagues, was quite enormous. But with the resilience of those who practice here, we were able to get to where we are. I will not want to bore us about the bloodless medicine surgery stuff, because this had been discussed since yesterday and today. And Dr. Ediefiu had really emphasized on this. But let me just emphasize one point, that bloodless medicine and surgery emphasizes the fact that we can use low-cost technology to manage our patient to avoid the use of allogenic blood transfusion with equal or better outcome and with patient satisfaction. I think that is the basic point that I want to put here in this presentation, that in anywhere you stay, you can use what you have to achieve. You don't need high fluting technology, need CT scan and all those stuff before you can practice bloodless medicine and surgery. And I have said here, which others have put, that is an evidence-based medical practice that aim at relying on patient-owned blood rather than the donor blood and achieving better patient's outcome. I can skip this. I had said that the concept is either poorly understood by our people or evokes negative connotation among practitioners that which result in skepticism and resistance, which I had mentioned. So it is important for us, the practitioner, and those who are interested in bloodless medicine, not to give up, but to continue to amplify the tenets, and particularly the result and the outcome of doing bloodless medicine and surgery. And in due course, you win a lot of faithfuls, which at the end of the day, the larger society will be better off. Why blood transfusion? Why blood conservative management? Others have been talking about risk of transfusion. It's everywhere. But most important to me is the cost. I remember yesterday, the cost implication of blood transfusion was actually being emphasized. But it's just not the direct cost of purchasing the blood, but the cost of making the blood safe, cost of storage, and sociocultural factors, which play more a decisive part in this our society, where somebody that comes from a particular environment will tell you that because this and that, she cannot accept blood. And even if you accept, he does not have enough money to buy the blood. And availability of donors. Recently, donor has been getting scared. Before now, we used to go for donor drive, and we have a lot of people donating. These days, you hardly do that. And also the storage facility to get this blood is also a big problem. And the screening protocols, which had been increasing recently. And of course, blood conservative management is a good medical practice. I emphasize good medical practice in the sense that you give the patient and the society the best and evidence-based practice. These days, practice is not only evidence-based, but it must be good practice. And we have, those of us who are in bloodless medicine surgery group know that the best practice for any practitioner in this our society is for you to try and limit the transfusion to patient. And of course, it also gives patient satisfaction. That's why we emphasize the need of conservative blood management. Speakers upon speakers have told us about the pillars of blood conservative technique. And of course, the immediate past presenter had really emphasized on this, that optimizing the hematocrit, minimizing blood loss, optimizing tissue oxygenation, lowering the transfusion trigger. This will form the pillar of my discussion. But more importantly, let me talk about uterine fibroid. Myomectomy is done for a patient with uterine fibroid. The fibroids that we are talking about are benign tumor of the uterus, and it is found mostly in women of reproductive age. Commoner in blacks, where it comes much early in the age, and they grow rapidly. There are evidence that show that there are certain characteristics of uterine fibroid amongst the blacks. And you also have it that there are more in number than what you find in other races. And they tend to grow in larger sizes. And more so amongst people that are multiparous. If you remember, many people will mention that uterine fibroid occurs in nulliparous or people of low parity. But in blacks, you see a multiparous woman para 5 that is having uterine fibroid. So that is why we want to check this profile, because this will also help us to project the type of patient that we'll have. It produces significant reproductive health and economic challenges amongst women and the society generally. We know that uterine fibroid have been linked to so many medical conditions and also affecting the woman well-being and other conditions that may affect our relationship with even the society. It is reported that 27.7% of women worldwide report negative impact of uterine fibroid at their work performance, which means it also affects the performance at the workplace. And if we consider that women are the major workforce in our society, we can imagine how much we lost. I just lifted this from a publication that the financial burden of uterine myoma on a US health care system is about 2.2 billion per year. And this is enormous, because if you can spend this amount of money to take care of a woman with myoma, it shows that it has a serious economic and personal impact. Uterine myomas have been linked to adverse outcomes, such as cesarean delivery, preterm labor and delivery, and malpresentation. That is the impact, the obstetric impact of uterine fibroid cannot be overemphasized, because all this led us to know that we need to really emphasize on how to manage these women. Etiologically, I may not bore you much because of want of time. It's largely unknown, but linked to a lot of reproductive growth hormones and other factors that are not necessarily related to hormones. Okay. There are some familiar tendency, predisposition. For want of time, let me just say that it's associated with other metabolic conditions such as diabetes mellitus and the PCOD, polycystic ovarian disease. And those of us who manage these women, we know what all this will do to the woman. Factors that contribute to development of uterine fibroid are this. Let me just move. Clinical consideration is necessary and key to management of this patient. Symptomatology are variable and depends on size, site, and number of myoma. Most of them are symptomatic and only diagnosed during routine assessment, either clinically or using imaging. Menstrual abnormality is common and most debilitating. And most women who report symptoms are likely to have one form of menstrual abnormality or the other. The pressure effect had also been noted. Pressure on bowels, big vessels, renal system, which some of them result in comorbid condition that we find in uterine fibroid. Anemia is the most important morbidity that is associated with uterine fibroid, and impact not only on the health of the woman, but the management and outcome of management. We have heard today, those who were there, how anemia is managed. And emphasis should be on correcting the anemia before surgery. Infertility and infertility management are also related with uterine symptomatology. Clinical consideration also, the pressure effect on all these systems are important. Pathology is key to selecting patients for bloodless myomectomy. I had shown here the location of fibroid. Most classification of pathological classification of fibroid is based on the location of the myoma on the uterus. We can see intramural. Most of them start from the fiber of the myoma and then get to other places. You have the subserous fibroid there. You have the subserous, submucosal, polypoids, and then intramural there. Cervical fibroid. There are some that are intraligamental inside the broad ligament of the uterus. And this is very important. It's not shown here because even if you have small size of the uterus and you have interligamental, it's likely to press on the ureters and other blood vessels and cause debilitating symptoms. You are always afraid of this particular type of myoma during surgery, interligamental and cervical fibroid. So we have to note that. And this is the gross pathology. I've just told you the locations. And this is live tissue of uterine fibroid removed at hysterectomy. You can see subserous, or there's some intramural that we find there. We need to take note of this. There are certain laboratory investigations, others have emphasized on it, but let me just choose the one that is so important in management of bloodless myomectomy. Complete blood count, particularly hemoglobin, WBC, group and cross-match, and rhesus factor. No. Blood grouping, we need to know the blood group and rhesus factor. And then platelets and clotting studies, including reticulocyte count, iron serum, all these have been mentioned today. They are so important because it helps you in screening and also thinking of comorbid condition that may influence your intervention during surgery. Blood chemistry like liver function tests, urine electrolyte creatinine. We do GTT routinely on most of the patients because of the relationship between diabetes mellitus and uterine fibroids, and also do urinalysis. We do imaging studies, ultrasound scan. Ultrasound scan is important because it will tell you the locations of the myomas on the uterus, CT scan, MRI, IVU. IVU, very necessary, particularly if the uterus is more than 20 weeks because of the relationship with the ureters. Hormonal studies are now very necessary. It has been noted that one of the most important factors that relate to etiology of uterine fibroid is the presence of prolactin in the myoma itself, local presence of prolactin and estradiol that perpetuate the growth of the myoma in a particular patient. I had mentioned this. In fact, this is one of the most critical part of my presentation, that you should be able, with all this clinical assessment, laboratory assessment, predict which of these patients is likely to come with higher chance of bleeding, despite all your efforts. Age. And it is noted that women with advanced age are likely to tolerate bleeding compared to people of young age, of course, because of certain changes. Parity. Women of low parity will tolerate better than women of high parity. High parity also go with age. Menstrual history. Women with menorrhagia, excessive bleeding, are likely to have impact because the myoma itself are likely to be in places that may be difficult to remove, either through laparotomy, hysteroscopy, or through laparoscopy. And because of this, such women are classified into certain form of intervention or the other. And the menstrual cycle, whether it is proliferative stage, it is luteal phase of the menstrual cycle, is important because if the woman is at the proliferative stage, bleeding are likely to be less. Medical facilities and equipment. This is critical also for you to assess your intervention in order to achieve your outcome. Personnel, they should be trained and knowledgeable in area of handling bloodless surgery. Previous medical and surgical treatment of fibroids because of attendant adhesions and other related pathology that would occur. A woman with comorbid conditions. This comorbid condition may not necessarily be diabetes mellitus and other comorbid condition that is necessitated by the fibroid itself, but the impact of fibroid on others like hypertension, renal disease, and anemia. Those are the conditions that you must check. Then pathological classification of the myoma, whether it's intramural, subserous, polypoid, and the number of the myoma itself, the size. Some are big, some are small. That will help you also to be able to arrange which type of intervention that are necessary. I just put this as schematic diagram to show how uterine fibroid is managed. We are interested in myomectomy. There are other interventions, either singly or in combination. For example, medical treatment and surgical treatment can be combined together to achieve certain results. And also, uterine artery embolization can be part of surgical intervention, or myomectomy in case you run into excessive bleeding. These are some of the surgical interventions that we do as bloodless medicine, bloodless surgery for uterine fibroid. It could be open laparotomy, mini laparotomy, minimal invasive. Minimal invasive also called endoscopic surgery. You can do ultra mini laparotomy. Vaginal approach can be used. Laproscopy. Laparoscopic myomectomy has gained ground recently and is regarded as the gold standard for bloodless myomectomy. But we're going to look at the merit and demerit if time permits. Robotic assisted laparoscopy. Of course, these are some of the newer techniques that have been used now. I had mentioned this, that sometimes you can combine embolization and myomectomy if need to be. Uterine artery occlusion and other treatment are there. Let's see myomectomy. Myomectomy is removal of myomas with intact uterus. You leave the uterus intact. Myomectomy is the most common plastic and reconstructive surgery of the uterus that have been well known, because you have to reconstruct the uterus and make it neo-normal after you had removed the myomas. It requires special training, experience, and proficiency. Emphasis should be made on this. Patients, practitioners that want to undertake myomectomy, mostly bloodless myomectomy, must have the requisite special training. Not that the first training will allow you to, and then have experience, which you build over time, and then become proficient before you undertake this. What is bloodless myomectomy? Essentially, bloodless myomectomy is myomectomy without associated blood transfusion, allogenic blood transfusion. We had mentioned all this. It is a multidisciplinary and modal approach. We have many modes and involve other personnel from other disciplines, which will help us to plan together what to do to achieve the best result. Clinical evaluation of patient and plan intervention are very, very important for bloodless myomectomy. Evaluation of the patient, Dr. DFU must emphasize on that, from history taking, physical examination, laboratory investigation, add them together, profile the patient, and then give specific area of intervention that is likely to achieve the best result and outcome. Now, bloodless myomectomy indications are usually fibroid with symptoms. We had mentioned most of the symptoms. Improve fertility management, not only fertility. There are some, I had mentioned some of the locations. There are some management of fibroid is just to improve the success of higher fertility management intervention. Because with fibroid, with attendant changes in the environment of the endometrium, may lead to failure to achieve pregnancy. It's also used to prevent medical complication, particularly improve quality of life. Emphasis is that myomectomy can may be indicated just to improve the quality of the woman's life. These are the type of myomectomy: open, open, and then laparoscopy, robotic, hysteroscopy. Bloodless myomectomy, select the gland properly. We had mentioned this severally. Preoperative management, essentially like we have been discussing since yesterday. Perioperative procedure is the emphasis that we are going to make now. Postoperative care, and then follow-up. I think I should skip this because this has been emphasized, but the last point here is you use this to categorize the patient to different modalities of surgery. That is the emphasis here. Now, intraoperative care. We had mentioned this also, pharmacological intervention, the use of vasopressin, and other vasoconstrictors, uterostonic, tranexamic acids, We've emphasized this severally. Intraoperative. Some of the methods that are important include the use of mechanical barriers, such as tourniquet and clamps. I always get thrilled by Bonnie Clamp because he was the first gynecological surgeon that introduced myomectomy and how to control blood loss. He had experience, let me just mention this. He had experience when he started that most of the patients were managed by hysterectomy. Even his wife in 1905 was giving hysterectomy when she was quite young. And the implication of that was quite serious to the extent that he went and discovered the Bonnie clamp, which help in minimizing blood loss during surgery. We can also use rubbers like tourniquet and other forms as mechanical barriers. Other measures like ligating the vessels and in a stepwise manner can also help in intraoperative management of bloodless myomectomy. Meticulous and appropriate operative technique. Let me just mention this. Meticulous in the sense that you have to take note of all the bleeding points and don't skip the technique that you have been told and taught and get proficient with. And also appropriate operative technique. For example, it is not very feasible in this environment for you to operate a woman that has a uterine fibroid of about 32 weeks of pregnancy with a phalansteal. That does not sound like appropriate technique, a phalansteal incision, or a modified phalansteal incision. So you must choose appropriate technique for a particular operation because you had already profiled patient to different form of intervention. This is the Bonnie clamp. I don't know whether we can see this. See the clamp at the isthmus level of the uterus, which occludes the uterine vessels, And it's very important. This is the first well-known method of preventing bleeding during myomectomy. And he was able to succeed at that time to manage most of the patients with myomectomy without the mortality that he had and excessive bleeding. So we always emphasize on Bonnie's clamp. There are so many modifications of this Bonnie's clamp now. Then this is our local one. I put this because this is what we do. I had mentioned at the beginning of my presentation that we emphasize on this. We just use uterine, we use a Foley's catheter, as you see here, and tie at that level that Bonnie's clamp was applied. And most times we achieve almost the same result, even with bigger uterus. You can see the Foley catheter here, tie here with a clamp, with this uterus, with this myoma coming out today. And this is what we were able to remove from that particular surgery. You can see the remaining part of the uterus after removing this using the myoma screw. Myoma screw also help. Like I said, appropriate surgical technique will help you to achieve what you want. We could do this despite our constraint in facility and materials. This is laparoscopic surgery. I had mentioned that the standard management of bloodless myomectomy is laparoscopic surgery. But laparoscopic surgery has its own drawbacks. And apart from cost, training, and selection of patients, it's also very important for you to have a base in terms of training, in terms of experience for you to achieve what you set out to. With this, it is believed now that initially when we started, laparoscopy was used to for small uterus, small myoma, but now laparoscopy is used to operate at even bigger uteri. You can see, I just put this. This is the cutting and the drilling and all that. There are certain factors. This is not the forum to talk about technique of laparoscopy, but just to know that laparoscopy is the basis, the main basis of bloodless myomectomy. Now, I will skip this. We have discussed this intraoperative care, using non-pharmacological technique, the autologous transfusion. We use this essentially. We have anesthetists here that are very vested in all this I put here. Intrauterine, intraoperative blood salvage, normovolumic, isovolumic hemodilution. These are some of the non-pharmacological techniques that we use here. And like Dr. Osoro said yesterday, we achieve result and we hardly have lost our patient. This is the modern cell salvage machine. We hope we could get to a point that we get this, because if we get this, I was just trying to compare. Say my time is up. Compare for us to know that there are certain differences between the laparoscopic surgery and laparotomy. Laparoscopic surgery appears to have longer operation time. You can see that. The diameter of myoma to remove are likely to be smaller in laparoscopy compared to that of bigger myoma. Estimated blood loss tends to be less in laparoscopy compared to laparotomy. Decline of hemoglobin concentration is better in laparoscopy compared to laparotomy. Complications and outcome are also shown there. Fever, more. There's no difference between fever and in both sides. We have other comparisons there. Special consideration, emergency myomectomy. It is very important to note that there are certain patients that, despite all your interventions, they still continue to bleed, or maybe torsion of the pedunculated fibroid or other associated condition may make you to intervene at that stage. And usually, all the preparation to prevent blood loss may not be available for you at the emergency myomectomy. But with the team that we have and the team of management that have been put in place, most time we also succeed. Obstetric and cesarean myomectomy. Let me skip all this. Incidental surgical intervention. Sometimes you want to go and do myomectomy, you see you experience other conditions. This is our institution. I want to talk about this patient because it's very peculiar. This patient refused blood transfusion, had this condition for 4 years, hemorrhage, exsanguinated, went to other places in Africa and in Calabar in particular. Spiritual center, using nutritional agent, using non-pharmacological methods to achieve result were not feasible. And then she came to our facility. For want of time, let me just download the investigation that she had was that we had 8 grams of hemoglobin. Other investigations were essentially normal. You can see other parameters there. The long and short of this thing, of the story, is that we were able to successfully manage this woman with uterus of about 32 weeks of pregnancy without blood transfusion, and she was doing well. This is the same woman I was talking about. We use open laparotomy, all that I mentioned there. We were able to use diatemy and rectal misoprostol. This is what we removed. The weight of the pieces of what we removed was 2.3 kg. And the blood loss, as you can see here, was about 500 mils. And that 500 mils were not during intraoperative period. She had postoperative oozing after that. Also, we had a retrospective study of some cases that we did, about 30 of them. Bloodless myomectomy was done in 15% of all myomectomies. We had a flowchart that showed this, that we progressively increase the number of the percentage of myomectomy done in this center, bloodless myomectomy done in this center. Because initially, maybe you can have 10%, 1%, 5%, but now we progress to 30%. You can see the profile of the patient and all this. Then the surgical outcome. Surgical time, you can see, was not so much. Estimated blood loss was this. Decrease in hemoglobin, you can see 1.3. 2 went to ICU. One of these was not due to blood loss. It was due to comorbid condition. And you can see the uterine weight that we use. The uterine weight that we use. Okay, in conclusion, there are growing strong clinical and literature and empirical evidence to support the practice of bloodless surgery, and particularly myomectomy. The outcome of bloodless surgery are not only comparable, but better than what transfusion would do. Thank you very much.